Dear friends, dear colleagues, let's talk about multimodal imaging of geographic atrophy. There are several imaging for geographic atrophy, color fundus photographies, blue fundus autofluorescence and near infrared autofluorescence, the fluorescent angiography and ICG, SDOCT and OCTA. Let's begin with the color fundus photographies. Historically, this was the main or the only way to image GA, and it was during years and years the gold standard imaging for evaluation of GA, the size and the limits of GA, but also for the progression of GA. Any demarcated area and of absence of RPE measuring at least 175 microns is the greatest linear diameter within the macula, with typically visible choroidal vessels and no sign of choroidal neovascularization is considered as an area of GA. The limitation of the fundus fluorescence, the fundus imaging, color imaging, is the media opacity, the variability of drusen and pseudo-drusen appearance, and interpatient variability of fundus pigmentation. Here is an example of a patient with a wide cataract. Actually, the gold standard is the fundus autofluorescence. The fundus autofluorescence must be considered as a tool, a part of the multimodal imaging in patients. The fluorescence analyzed is mainly coming from the lipofuscin of the RPE cells. The geographic atrophy is determined by the loss of this autofluorescence. There are several steps. First, an hyperfluorescence linked to an increase of phagocytosis and increased formation of lipofuscin. Secondarily, spots of hypoautofluorescence because of a loss of phagocytosis and loss of lipofuscin. And then there is a GA because of a loss of RPE cells. The autofluorescence is demarcated, is shown by an hypoautofluorescence with an hyperautofluorescence borders. Here are two examples of patients, and on the right frame we can guess a partial forward sparing. Here is a follow-up of a patient with a minimal GA lesion, and with years you can see the reticular pseudodrusen, the increasing lesion, and some other lesion appearing, multiple dots of hypoautofluorescence. That is the sign of the growing of GA. This was mainly demonstrated by the group of Frankls that identify all the kind and all the forms of GA based on autofluorescent imaging, but also the patterns of the hyperfluorescence associated with the hypofluorescence, known, focal, patchy, banded, diffuse, and diffuse trickling. Here is the example of autofluorescence in a patient with GA, and you can see very, very different patterns. There is a tool for evaluation of the follow-up and the growing of the GA lesion based on autofluorescence. This tool is called Region Finder on the Spectralis device. And the main advantage of that is to analyze the progression and to quantify the progression of the GA lesion. Here are some examples of different patterns evaluated by the Region Finder software. and we can quantify the progression with this tool. So now let's talk about the foveal sparing in GA. One of the limitations of the blue autofluorescence is the difficulty of obtaining good quality image in the presence of cataract, and most of the patients have both cataract if they are not pseudophakic. And the second point is the macular xanthophiles that absorb the excitation light and block the autofluorescence from the underlying RPE. Here, the F autofluorescent frame, we can guess the xanthophyll pigment, but we are not sure it is part or not of the lesion. On the near infrared, the foveal sparing is much more obvious. So the autofluorescent frame may overestimate the atrophy that is better detected with the near infrared imaging. Here is an example of autofluorescent near infrared, and that perfectly correlate with SDOCT. Two examples of near infrared imaging that reveal and that demonstrate the foveal sparing in this patient. Fluorescent angiography and ICG are poorly used in the context of GA, but can be used for differential diagnosis or in any doubt of CNV. Oh, just one point about, we didn't talk about the this other option that is adaptive optics for foveal sparing. It can be used also for foveal sparing analysis and counting the cells on this lesion. Let's talk about FA. We can observe here a window effect that is revealed by an hyperfluorescence, but without any staining and without any leakage of the dye. Another example of FA. ICG shows an hyperfluorescence and visualization of the choroidal vessels and can be used sometime in any doubt of associated CNV. Here is FA and ICG on this patient, no CNV. Let's talk now about SDOCT. One of the first paper is coming from this group led by Frank Hals. The OCT allows analysis of photoreceptor and RPE layers and the analysis of the limits and borders of the GA lesion that is marked by the posterior hyperreflectivity. There is no consensus, a classification, but this classification is mainly used in clinical research, poorly used in real life. This classification have advantage of a consensus in giving name to the stage of atrophy for each SDOCT scan. There are 4 different conditions: a complete RPE and outer retinal atrophy, CRORA, an incomplete RPE and outer retinal atrophy, IRORA, a complete outer retinal atrophy, CRORA, and incomplete outer retinal atrophy, IORA. All this imaging can be also mixed. It's not only pure imaging, but the function can be mixed with the functional analysis that is a microperimetry, with high correlation between the GA zone and the microperimetry function. Let's talk now about the mixed lesion, GA plus CNV. There are, let's say, 2 ways of evidencing both GA and CNV. On SDOCT, you can guess some RPE and some exudative features sometimes. ICG can show and evidence the flow. Here's another example here on the elevated RPE, a small FIPED here, and here hyper cyanescence on this patient, and the follow-up after the treatment. More easily, the presence of CNV can be determined, can be evidenced by OCTA, and OCTA should be performed at least at the first examination when we have any doubt on SDOCT to be sure if there is or not some CNV that can be quiescent without exudative feature. We'll finish now with a peculiar phenotype, the EMAP, that was described by Amel some years ago. It's a kind of GA with polycyclic borders, bilateral symmetry, and a vertical axis. One of the facts is that it occurs in younger patients, around 50 or 60 years old, associated with pseudodrusen-like deposits and pavimentous degeneration on extreme periphery. Here is a complete phenotype. You can see the vertical axis here, the vertical axis of GA, and on the pavimental lesion on the extreme periphery on this patient. This lesion is commonly associated with hemeralopia, sign of choroidal thickness, and a rapid progression of the lesion. Here is an example of EMAP with reticular pseudodrusen, a rapid progression, very rapid progression of the lesion, and a very thin choroid on this patient. Thank you. Thank you for your invitation. It was a pleasure to discuss about multimodal imaging.